What if the key to treating one of the most common, like most aggressive male cancers was actually, well, a heavy dose of female hormones?
Yeah, I mean, it sounds completely counterintuitive, right?
Right. Like if you were pitching this idea a few decades ago, you probably would have been, laughed out of the room.
Absolutely.
But today, we're going to look at how a simple estrogen patch, the kind historically associated with hormone replacement therapy for women, is going toe-to-toe with some of the heaviest, most intense cancer treatments on the market.
It's a really profound shift in how we approach oncology. Because, well, we're so conditioned to think of cancer treatment as this biological scorched earth campaign.
Yeah, just destroy everything in its path.
Exactly. But this data, it presents a radically different philosophy.
So, welcome to our deep dive. Today, our mission is to unpack a massive 15-year medical trial out of the UK that is completely reframing how we treat locally advanced prostate cancer.
And it really is a landmark study.
It is. And even if you don't have a medical background or, a personal connection to this specific disease, you're going to want to hear this.
Because it's not just a list of survival statistics.
Exactly. It's this fascinating story about biological cause and effect. It's about how solving one problem in the human body almost always creates a new one.
Right.
And how modern medicine is finally trying to prioritize a patient's actual lived experience rather than just treating them like a biological math problem.
Yeah, the source material here is a major phase 3 randomized trial. And it compares the traditional standard of care, which is this really heavy-duty treatment known as LHRH agonists, against that simple daily estrogen skin patch.
A patch. It's wild.
It is. And the underlying biology of why this even works is incredibly elegant.
Well, let's start with the biology then, because
Yeah.
to understand why this patch is such a revelation, we need to understand the old way of doing things, right?
Right.
So what is the fundamental mechanism driving prostate cancer, and how have we traditionally tried to stop it?
So the core issue with prostate cancer is that the tumor cells need a specific fuel source to grow and multiply.
Okay.
In this case, that fuel is androgens, specifically testosterone.
Got it.
If the body's producing testosterone, the cancer is feeding on it. So the foundational strategy for treating this disease is androgen deprivation therapy. You basically just have to cut off the fuel supply.
Okay, that makes logical sense. Starve the tumor.
Exactly.
And historically, how do we shut down that fuel supply?
Well, for decades, the gold standard has been drugs called LHRH agonists.
LHRH.
Yeah, it stands for luteinizing hormone-releasing hormone. And the way these drugs work is actually a bit of a biological trick.
How so?
They artificially flood the brain's receptors with a synthetic signal to produce testosterone.
Wait, to produce more? I thought we wanted less.
Right. But initially, the body produces a massive surge of it.
Yeah.
But very quickly, the receptors get completely overwhelmed and burn out.
Oh, wow.
Yeah, the system essentially short circuits and shuts down production entirely.
So it's not like a gentle deceleration. It's like starving a car's engine of fuel to stop it from speeding. But to do that, you floor the gas pedal until the engine seizes up and just stops working.
That is an incredibly apt way to describe it.
Yeah.
And, it is highly effective at stopping the cancer.
Sure.
The testosterone levels plummet, the tumor is starved, and the disease is halted. But this is where that biological cause and effect comes into play.
Because you broke the engine.
Exactly. Because when you artificially shut down a man's testosterone production, you aren't just depriving the cancer, you're depriving the entire body of a critical hormone.
Right.
Which leads to an unintended severe consequence, extreme estrogen depletion.
Wait, let me stop you there, because that's going to sound very strange to a lot of listeners. Estrogen depletion in a man.
I know, it sounds backwards.
Yeah, why would shutting down testosterone have anything to do with estrogen?
What's fascinating here is that it's one of the most misunderstood mechanisms in human biology. We colloquially categorize testosterone as the quote-unquote male hormone and estrogen as the female hormone.
Right, that's what we're taught.
But the reality is far more fluid. Both hormones are present and essential in all bodies. In men, testosterone doesn't just stay testosterone. A portion of it is constantly being converted into estrogen through an enzyme called aromatase.
So male bodies actually manufacture their own estrogen by, recycling their testosterone.
Precisely.
Yeah.
And that resulting estrogen isn't just lingering there, it has a job.
Okay.
In men, estrogen plays a vital role in maintaining bone density, regulating lipid metabolism, and crucially, managing the body's internal temperature control in the brain's hypothalamus.
Oh, I see where this is going. If the LHRH agonists shut down the body's ability to make testosterone, there's no raw material left to convert into estrogen.
The well runs completely dry. And that sudden, severe lack of estrogen throws the body's internal thermostat into total chaos. By creating this estrogen depletion, the standard treatment triggers a cascade of debilitating side effects. And the most universally agonizing for these patients are severe hot flashes.
And we should clarify what a severe hot flash actually entails, especially for, a man in his 70s who is already battling cancer.
Yeah.
This isn't just feeling a little stuffy in a warm room, is it?
Not at all. A severe clinical hot flash is a profound, system-wide physiological event.
Jeez.
We're talking about sudden, intense waves of heat radiating through the chest and face, profuse sweating that requires changing clothes multiple times a day, and, really significantly, severe sleep disruption.
Because they happen at night, too.
Yeah. When a patient is waking up drenched in sweat 4 or 5 times a night for months on end, the sleep deprivation alone becomes catastrophic to their mental and physical health.
So the traditional treatment is fundamentally a trap. You stop the cancer, but you plunge the patient into systemic physical misery because you broke their body's temperature regulation, which naturally leads to the premise of this new trial. If the misery is caused by a lack of estrogen, well, why not just give them estrogen?
Right. It is the most logical, biological question you could ask. If they need estrogen, supply it.
Mm-hmm.
But medical history shows us that the delivery method dictates everything.
Okay, let's unpack this, because this is where the story gets complicated. The researchers in this trial didn't just hand these men an estrogen pill to swallow with their morning coffee.
No, they didn't.
They used something called TE2 Transdermal Estradiol, an estrogen patch that delivers exactly 100 micrograms of estradiol through the skin every 24 hours. Why go through the trouble of formulating a skin patch? If estrogen is the solution, why was oral estrogen just, off the table?
Because treating prostate cancer with oral estrogen has been tried in the past.
Oh, has.
Yes, and the results were clinically disastrous. Taking heavy doses of estrogen orally caused an unacceptable rate of thromboembolic events.
Which means?
In simple terms, severe, potentially fatal blood clots.
Wait, how does swallowing a pill cause a blood clot, but absorbing it through the skin doesn't? I mean, it's the exact same chemical entering the body, isn't it?
It is the same chemical, yes, but it takes a completely different physiological journey.
Okay.
When you swallow an estrogen pill, it enters the stomach, gets absorbed through the gastrointestinal tract, and gets routed immediately to the liver. This is called first-pass metabolism.
Right.
The liver's job is to act as the body's primary filtration plant. When it gets hit with a massive, concentrated spike of oral estrogen all at once, it aggressively processes it.
And that's bad.
Well, a byproduct of the liver rapidly metabolizing estrogen is the overproduction of coagulation factors, the proteins that cause your blood to clot.
Oh, wow. Okay, to use a bit of an analogy here, it sounds like taking estrogen orally is like driving straight into a massive traffic jam in the digestive system and liver. It causes a huge pileup, which panics the system and triggers those blood clots.
That's a great way to look at it.
But the transdermal patch, the skin patch, takes the back roads. It slips directly through the skin, into the microscopic capillaries, and straight into the general bloodstream. It bypasses that danger zone entirely.
That is exactly the mechanism at play. By avoiding the liver's first-pass metabolism, the patch delivers a slow, steady 24-hour trickle of estrogen.
So no traffic jam.
Exactly. It never triggers that massive spike in coagulation factors. It completely sidesteps the danger of blood clots.
Okay, so the patch is safe, but how does putting estrogen into the bloodstream actually stop the prostate cancer? I mean, I understand that it fixes the hot flashes by giving the body the hormone it was missing, but how does it solve the core problem of starving the tumor of testosterone?
So it utilizes something called the HPG axis.
The HPG axis?
Yeah, which is basically the body's hormonal feedback loop. The brain has sensors that constantly monitor hormone levels in the blood. If hormone levels are low, the brain sends a signal down to the testes saying, hey, make more testosterone. But if the brain senses that there is an abundance of sex hormones circulating in the blood, it sends a negative feedback signal to shut production down.
So by introducing a high, steady dose of estrogen through the patch, you're essentially tricking the brain.
Yes.
The brain detects all this estrogen, assumes the body's hormone tanks are totally full, and tells the testes to completely halt testosterone production.
Exactly. It achieves a delicate, brilliant biological dual action. It shuts down the cancer's fuel supply via that feedback loop, while simultaneously providing the exact hormone needed to regulate the internal thermostat and prevent the hot flashes.
In theory, it sounds flawless,
It does.
but an elegant theory doesn't cure cancer. And that brings us to the trial itself, because proving this actually works took an almost unbelievable amount of time and effort.
Yeah, 15 years.
Right. This was a phase 3 trial that ran from 2007 all the way to 2022. 15 years of continuous data collection. Why did it take a decade and a half to prove this works? What were the researchers so cautious about?
Well, in oncology, you're dealing with life and death on a massive scale. You simply cannot rush long-term survival data.
Sure.
Prostate cancer often progresses slowly. So to genuinely know if a new treatment keeps a cancer from spreading 5–10 years down the line, you literally have to wait 5 or 10 years to observe the patients.
That makes sense.
And the scope here is staggering. They recruited 1,360 patients across 75 different clinical centers in the UK.
Let's talk about those patients. The data notes the median age was 72, but the clinical staging is where we need to clear up some medical jargon.
Okay.
The trial notes that 85% of these men had a T3 tumor stage and 65% had an N0 nodal stage. What does that actually mean for the person sitting in the exam room?
Right, so the TNM staging system is how oncologists map out exactly how far a cancer has advanced. The T stands for tumor size and local spread. A T3 stage means the cancer isn't just a small contained lump anymore.
It's growing.
Yeah, it has actually grown large enough to break through the outer capsule of the prostate gland.
So it's locally aggressive, it's trying to spread outward.
Yes, but the N stands for nodes, the lymph nodes, and those act as the highway system for cancer to travel to the rest of the body. An end stage means the cancer has not yet invaded those lymph nodes.
Got it.
So combining those, we're looking at men whose cancer is large, aggressive, and breaking out of the prostate, but hasn't yet caught a ride to the rest of their organs. It is a critical, high-stakes window for treatment.
Here's where it gets really interesting. The trial was designed to measure 3-year metastasis-free survival, essentially. Does the treatment keep the cancer from spreading to other organs for at least 3 years?
Correct.
But the structure of the trial is something we need to dissect. The researchers designed this as a non-inferiority trial, which feels like an incredibly unambitious word.
I know, it sounds a bit weak, right?
Yeah.
Hold on, non-inferiority. If you're running a 15-year study, shouldn't the goal be to prove your new estrogen patch absolutely crushes the old treatment? Why design a trial just to prove you are not inferior? It sounds counterintuitive, but in modern medical research, non-inferiority trials are vital, especially in oncology.
Why is that?
The ethical reality is that the standard treatment, those intense LHRH agonists, are already phenomenally effective at keeping people alive. The ceiling for survival is already incredibly high. You practically cannot beat those survival numbers.
So if you try to design a trial proving the patch has a higher survival rate, you're setting yourself up to fail against an impossible metric.
Correct. The goal here isn't to build a more lethal weapon against the cancer. It's to build a much gentler weapon that works just as well.
Okay.
The value of a non-inferiority trial is proving that a patient can switch to a treatment with vastly better quality of life without sacrificing a single drop of efficacy. They set a non-inferiority margin of 4 percentage points.
Meaning as long as the estrogen patch's survival rate is within 4% of the heavy-duty injections, it's considered a massive medical triumph.
Exactly. And when they finally crunched the numbers after 15 years, the patch absolutely held the line. At the 3-year mark, the metastasis-free survival rate for the patients on the estrogen patch was 87.1%. For the patients on the traditional LHRH agonists, it was 85.9%.
They're essentially identical.
They are. The researchers calculated a hazard ratio of 0.96.
Let's break that number down for the listener. A hazard ratio is basically comparing the risk of a bad event happening in one group versus another, right?
A hazard ratio of exactly 1.0 means the risk is perfectly identical between both groups.
So a hazard ratio of 0.96 means the patients on the simple skin patch actually had a microscopic 4% lower risk of the cancer spreading than the people on the intense injection.
Exactly.
Functionally, it is a dead heat and well within that margin of success.
It is a phenomenal result. And the 5-year overall survival rate echoed that too. 81.1% survival for the patch group versus 79.2% for the injection group.
That's incredible.
And we know exactly why they tied. Both treatments successfully achieved castrate levels of testosterone in roughly 85% of the patients within the first year.
I want to give some context to that term, castrate levels, because it highlights just how aggressively both of these treatments shut down the body.
Yeah, it's intense.
The data defines castrate level as dropping testosterone below 1.7 nanomoles per liter. For a normal, healthy adult male, testosterone usually sits somewhere between 10 to 35 nanomoles per liter.
So dropping it below 1.7 is an absolute systemic shutdown. The fuel tap is completely turned off.
Okay, so biologically, chemically, and statistically, we have a tie. Both treatments starve the cancer. Both treatments keep roughly 80% of patients alive and metastasis-free at 5 years.
Right.
So, what does this all mean? If the clinical efficacy is a tie, how does a doctor decide which one to prescribe? What is the catch here?
Well, when survival rates are a tie, the tiebreaker completely shifts. It moves away from the lab results and focuses entirely on the daily lived experience of the patient.
The quality of life.
Yes. It comes down to the side effect profiles. And this is where the two treatments diverge wildly. Let's look at the traditional LHRH injections first. As we discussed, dropping testosterone and depleting estrogen caused hot flashes in an overwhelming 89% of patients.
Almost 9 out of every 10 men.
Yes. And 37% of those patients suffered severe, debilitating hot flashes.
Lawful.
Now contrast that with the men wearing the daily estrogen patch. The occurrence of hot flashes plummeted to 44%, and the severe cases dropped to just 8%.
That is a staggering reduction in systemic misery.
It really is.
The estrogen did exactly what it was supposed to do for their internal thermostats. But, I mean, I know biology rarely gives out free passes. You don't just pump female hormones into a male body for years without a physical reaction.
No, you don't.
What is the catch with the patch?
The catch is a distinct physical change. By introducing a steady stream of estrogen into these men, 85% of the patients on the TE2 patch developed gynecomastia.
Gynecomastia.
Meaning breast tissue growth.
Correct. 85% experienced it, and 37% of those cases were classified as severe. Wow.
To compare, only 42% of the men on the traditional injections experienced any gynecomastia, with only 9% being severe.
I want you, the listener, to really put yourself in this scenario. Imagine sitting in your oncologist's office. You have a highly aggressive tumor. Your doctor slides 2 options across the desk. Both have the exact same 80% chance of keeping you alive for the next 5 years. Both will effectively shut down your testosterone.
But there's no flawless, side effect-free magic bullet.
Exactly. It's not about finding a flawless treatment. It's about choosing your trade-off. You have to actively choose your own biological trade-off.
It forces a deeply personal decision.
You are essentially choosing between the intense systemic discomfort of severe hot flashes with the injections or the physical body changes of gynecomastia with the estrogen patch.
If we connect this to the bigger picture, this is why this 15-year trial is such a monumental shift in medical philosophy.
How so?
Well, in the past, clinical trials were a race to find a single definitive winner. The goal was to prove treatment A was mathematically superior, so we could throw treatment B in the trash.
Right.
But this trial doesn't do that. It proves that both are excellent at fighting the disease, but they offer 2 completely different pathways of suffering.
It's the ultimate victory for patient autonomy.
Exactly. It empowers a doctor to sit down and say, which side effect are you psychologically and physically better equipped to tolerate?
Right, because everyone is different.
For some men, the physical alteration of breast tissue growth is emotionally intolerable, and they will grit their teeth through the hot flashes.
Sure.
For others, the chronic sleep deprivation and sweat-drenched misery of a severe hot flash is absolute torture, and they'll gladly accept the gynecomastia in exchange for a peaceful night's sleep. We are finally learning to measure quality of life with the exact same scientific rigor that we measure survival rates.
Let's bring all of this together. We started by looking at a medical establishment that relied on a heavy-duty intervention LHRH agonists that effectively starved prostate cancer of testosterone, but collaterally stripped the body of estrogen, leaving men to suffer through intense, debilitating hot flashes.
And in response, researchers took a 100 microgram transdermal estrogen patch and proved, across 15 years and over 1,300 patients, that it is just as lethal to the cancer.
It matched the survival rates perfectly. And by utilizing a skin patch delivery method to take the back roads around the liver, it bypassed the deadly risk of blood clots. It allowed doctors to safely resupply the body with estrogen, drastically cutting down on those hot flashes, trading them instead for the physical side effects of gynecomastia.
It offers patients a powerful, highly effective alternative to manage their own bodies during the hardest fight of their lives.
For anyone listening who loves uncovering the mechanics of how things actually work, this deep dive is a brilliant reminder to constantly question the standard way of doing things. Even in fields as advanced as high stakes and as heavily researched as oncology, stepping back and examining the biological mechanisms can yield incredible alternatives.
Absolutely.
It proves that medical innovation isn't always about inventing a more powerful poison to kill a disease. Sometimes true innovation is about utilizing a smarter, more elegant mechanism that prioritizes the human experience and not just the raw survival data on a clinical spreadsheet.
And looking at the bigger picture, it leaves you with a fascinating question to consider.
What's that?
We just saw how simply changing the delivery system, moving from an oral pill that caused liver complications to a simple transdermal skin patch, completely bypassed a fatal side effect. It literally rescued estrogen from the medical scrap heap and turned it back into a highly effective cancer treatment. It really makes you wonder, what other failed or discarded medical treatments from the past century might actually be highly effective cures, just waiting for us to invent the right delivery method.